Hello and welcome to Anesthesia in Pregnancy or Obstetric Anesthesia. My name is Haitham Makawi, Consultant of Anesthesia and Intensive Care, Head of ICU Department, Dream Maternity Hospital, Khartoum, Sudan, and I will be delighted to take you over this lecture on obstetric anesthesia or anesthesia in pregnancy, and I'll start by defining pregnancy. So, pregnancy is defined as the state of carrying a developing embryo or fetus within a female body. More formally, WHO explains pregnancy is the period from the conception, that's mean the fertilization of an ovum by sperm, until the birth of the baby. Usually, it's 14 weeks from the first day of the last menstrual period. This definition encompasses all stages of gestation, beginning with the implementation of fertilized egg in the uterus and continuing through the embryonic and fetal stage until delivery. So the duration is 280 days or 40 weeks from last menstrual period, and it's divided into three trimester, first trimester, second trimester, third trimester, respectively. And classification is used to monitor the reproductive health indicator, for example, maternal mortality and antenatal care. So why do we focus in anesthesia in pregnancy or pregnancy anesthesia during pregnancy? Because of uh, vast maternal physiological change that take place in the parturian body and the fetal implication of the anesthesia procedure and surgical process or the surgical procedure and increased risk of aspiration and potential difficult airways in parturian. And it's also important to minimize the fetal drug exposure. For American Society of Anesthesiologists, classified pregnancy as a class 2. So always remember that it's equivalent to mild systemic disease. So that's in a healthy pregnant woman. For example, if the parturient having a gestational diabetes or preeclampsia, then she will become SA3. And if she have severe eclampsia, cardiac disease of pregnancy, to become SA4, 5, and 6 are the same. So always remember ASA classification is a ASA2. So trimester-based classification for anesthetic consideration. First trimester, as we mentioned, we have three trimester. First trimester start from week 0 till week 12. And this is the teratogenic risk uh, occur or have a great potential beside the nausea and vomiting, and there is a high risk of miscarriage. The second trimester start from the 13th to 27th weeks, and the safest for non-obstetric surgery. So if you have urgent procedure, you can delay it to the second trimester. The third trimester start after the 28th week, so till delivery, and there is a high risk of aspiration and aortocaval compression and preterm labor risk. So there was a depreciated fatal risk category according to the Federal Drug Administration or authority. So historically, they used to use A, B, C, D, X classification. Drugs which are labeled A are safe in pregnancy. B and C, there is a varying animal and human evidence that they affect the fetal growth or have potential. De-risk to fetus might be justified, X contraindicated in pregnancy. Also, according to urgency of procedure or surgery, or urgency-based surgical classification of American Heart Association and American Society of Anesthesia, it can be divided into elective, urgent, and emergent. So if it's elective, then please defer until postpartum. If it's urgent, proceed ideally in the second trimester. Emergent should be proceeded immediately without delay, for example, appendicitis and trauma. So anesthetic technique also can give us another classification depending on the technique. For example, you have neuroaxial, for example, spinal, epidural, or combined. A general anesthesia, for example, when there is a contraindication to neuroaxial or there is emergencies, for example, high risk of aspiration, and we can use local or regional blocks, for example, prenatal procedures or a physiotherapy. Okay, and we can use also the urgency-based classification. So anatomical and physiological change of airways in pregnancy. Upper airways became edematous, especially the mucosa, due to the hormonal effect of estrogen and progesterone, which lead to capillary engorgement and fluid retention. So there is a upper airway engorgement and fluid retention that can lead to difficult mask ventilation, difficult laryngoscopy, increasing bleeding tendency. So try to avoid nasal airways or nasotracheal intubation as much as you can. Consider using shorter plates for direct laryngoscopy, reduce pharyngeal area, and there is a worsening of Malambati score. And Malambati, by the way, is a leading famous anesthesiologist, and he was obstetric anesthesiologist. And due to the potential difficult airway, he developed the Malambati scoring system. Let's remember always that the parturian have a rapid desaturation tendency during apnea due to decrease of functional residual capacity and increased oxygen demand. So, and let's remember that there is 12%, 10 to 12% weight gain in parturian. This will lead to airway soft tissue enlargement beside the breast enlargement, which will interfere with the mechanical movement and ventilation of parturian. So laryngoscopy will be difficult. That's why Malambati invented his Malambati score. So to make brief, difficult intubation, rapid oxygen desaturation, a risk of aspiration. Those are the three hallmark. So there is an eightfold increase in difficult intubation risk compared with non-parturian or non-pregnant, according to Shirley's study at 1216, due to the edematous airway and the effect of the hormone we spoke about. So you can enhance visualization using video laryngoscopy, or if the thing that you're more convenient with and experienced with. As I mentioned, there is a rapid oxygen desaturation because of the decreased functional residual capacity and increase on oxygen consumption because of the presence of the fetus and mother. So it's recommended to pre-oxygenate thoroughly to 3 to 5 minutes using 100% oxygen or 8 vital capacity breath when not feasible. So risk of aspiration due to decreased lower esophageal sphincter tone, increased intra-abdominal pressure, and delayed gastric emptying. We will be speaking about those. So rapid sequence induction is mandatory for general anesthesia with cricoid pressure and also aspiration prophylaxis, for example, using non-particulating agents, for example, sodium citrate. So anesthetic implication of airway management. Preparation, always have full airway assessment before any anesthetic procedure. Always anticipate difficult intubation. Prepare alternative devices, video laryngoscopy, boogie, supraglottic airway, and those are essential. Positioning, always have a ramp up or head elevated laryngoscopy position, help position, improve alignment and visualization of the spinal of the vocal cords. Apply uterine displacement, left lateral uterine tilt, especially after 18 months when the aortocaval compression happens. Always induction and intubation, use rapid sequence intubation with cricoid pressure. Use agents like thiobentol, propofol, avoid ketamine when feasible, unless if the patient hypertensive, and I'll speak about that uh, briefly in few after few slides. So difficult airway algorithm on static. Briefly, we can say call for help, pre-oxygenate with 100% oxygen. Uh, Try to rapid sequence intubation attempt with experienced anesthetist. If failed, position or retry with a different device. use supraglottic airway, for example, second generation LMA, it decrease risk of aspiration. Wake the patient if possible, and if failed, if you cannot proceed with front of the neck access, uh, well, that's your last resort. So, this is the DAS algorithm, master algorithm for obstetric general anesthesia in and failed tracheal intubation. Algorithm A, it's a safe obstetric general anesthesia. So, pre-induction planning and preparation, team discussion. Then you proceed for rapid sequence induction. Consider face mask ventilation, as we mentioned, and then proceed with the laryngoscopy. Try maximum two intubation attempt. The third should be attempt by experienced colleague, the most experienced. If success, then verify successful tracheal intubation and proceed, and then plan for maintenance and extubation. Algorithm two, when there is an obstetric failed tracheal intubation, immediately call for help, declare failed intubation, maintain oxygenation using a supraglottic airway device. Uh, for example, two attempts or face mask. There is a high risk of aspiration here. Try to reduce the risk of aspiration and prepare yourself for aspiration. So if you succeed, then stop and think if it's mm, essential or safe to proceed with the surgery immediately. If yes, then proceed. If no, then awaken the patient. Algorithm three, this is the cannot intubate, cannot oxygenate scenario. Declare CICO, cannot intubate, cannot oxygenate. Try to give 100% oxygen. Exclude causative like laryngospasm. Ensure adequate neuromuscular blockage, and consider the front of neck access. Then, if succeeded, proceed to like question mark, should I proceed or should I awaken the patient, delay the procedure, and accordingly you may proceed or stop. So the physiological changes that happen in the respiratory system is to meet the increased oxygen consumption demand by the parturient and the fetus, and the decrease in the functional residual capacity by 20%. So the body increased minute ventilation, respiratory rate, and tidal volume. That's lead to mild respiratory alkalosis. The mechanism that lead to increase of the minute ventilation is the effect of progesterone on the respiratory center, and that's lead to decrease in the partial carbon dioxide to 28 to 32 millimeter mercury. That will lead to mild respiratory alkalosis, and this will lead to renal compensation. The body will start retaining bicarbonate and to create sort of metabolic acidosis to compensate. So this is a compensation. But yet this alkalosis have effect on the parturient. So on potassium, it lead to mild hypokalemia. So and that's because of the hydrogen shift out of the cell, and and potassium shift into the cells, and that's the potassium hydrogen exchange. Ionized calcium is reduced because of the alkalosis, increase the binding of calcium to albumin, though albumin in pregnancy is diluted and reduced, but still yet the calcium bind to albumin. So this lead to the reduction on the free active calcium. And also we have to remember here that the fetus also drain the mom of calcium. So magnesium, also there is a variable reduction due to increase of renal loss with alkalosis, and also it's potentiated by plasma expansion. Respiratory alkalosis enhance also the renal phosphate secretion, and also compensatory bicarbonate loss may alter uh, chloride reabsorption. So the alkalosis have a clinical implication for anesthesia and intensivist. For example, hypokalemia increase the risk of arrhythmia, especially with volatile agents or beta agonist. And also they may worsen the neuromuscular block or delay the recovery. So it's advised to monitor ECG and serum potassium closely especially during labor or general anesthesia. Hypocalcemia can lead to tetany, seizures, and laryngospasm. So it's very important in eclamptic patient because we have to remember also magnesium antagonize calcium, and calcium antagonize magnesium. So there is a high potential of laryngospasm if the patient is eclamptic. So, in hypophosphatemia, contribute to muscle weakness and poor weaning from ventilation in ICUs. So, overall, alkalosis reduce tissue oxygen delivery. It causes left shifting of oxygen hemoglobin dissociation curve. So, try to always maintain normal ventilation during general anesthesia. Avoid excessive hyperventilation in ventilated obstetric patient. Alkali B is a monomer that can help you to remember that it's lowers alkalosis lead to lower of potassium, lower active calcium, lower magnesium and sulfate. And okay, we move now to the gastrointestinal change in pregnancy. Let's start with the lower esophageal sphincter. The tone is decreased due to the progesterone effect, and it's induced most muscle relaxation, and it's observed from the first trimester and peak at the third trimester. That's leading to reflex, gastroesophageal reflex, aspiration risks. So aspiration risk increase during induction. So you always use rapid sequence induction in second and third trimester. Always elevate head, pre-medicate with proton pump blockers or metoclopramide. Okay. Uh, there is a delayed gastric emptying also due to the mechanical compression of the gravid uterus and the hormonal slowing progesterone of gastric emptying. It's so significant in the third trimester, leading to bloating and nausea and vomiting and high risk of aspiration. Always treat as a full stomach after 16 weeks of gestation. Always assume risk of aspiration. Avoid opioid pre-induction unless necessary. Consider prekinetic, for example, metoclopramide if stable or suitable. Gestational change in pregnancy. Let's summarize them. Lower esophageal sphincter decrease the tone. So this is due to progesterone-induced smooth muscle relaxation from the first to till the third. So that's cause of acid reflux and risk of aspiration or Mandelson syndrome. We spoke about Mandelson syndrome and aspiration in the uh, preclinical course. Delayed gastric emptying, we spoke about it because of the mechanical and hormonal action. And if feasible, you can use prokinetic agent. Increase gastric volume that goes progressive through pregnancy. Okay, and also increase of acidity. So use sodium citrate 30 ml before anesthesia pre-op in elective cases or even in cesarean section. Uh, 30 ml of sodium citrate 30 minutes prior to the induction. Uh, Liver function also should be observed because of a lot of problems, HELP syndrome, or for example, pregnancy-induced or fatty liver of pregnancy. So let's remember that always there is a hemodilution, an increase in the plasma volume going starting from the pregnancy in all trimester, and there is a decrease in albumin, increase in coagulation proteins, and there is an increase in alkaline phosphatase, but it's a placental in origin, it's not from the liver, and there is unchanged AST-ALT ratio. So always remember to adjust the dose of albumin bounding drug because there is increase of free drug fraction. For example, phenytoin or local anesthetic, you may need to reduce the dosage by 30% because the availability of the drug immediately because of the reduction of albumin, circulatory albumin. So you won't need the standard dose. There sort of is those adjustment. So also one of the common problems is appendicitis Or let's speak briefly about GI emergency in pregnancy. For example, appendicitis, or one of the common problem observed in pregnancy due to shifted anatomy and delayed diagnosis, and that can lead to peritonitis and fetal loss, or even the operation can lead to fetal loss. It's an emergency. We have to immediately go for it. So it can happen in any time, but usually in the second trimester. If you want to use imaging, remember to use MRI or guarded compression ultrasound. Do not delay surgery intervention. You can use general anesthesia, try to prophylactic or preventing aspiration. And after 18 months, week of gestation, remember to reverse the aortocaval compression. Use left lateral uterine tilt. This is another effects on the gastrointestinal system is decrease of gastrointestinal motility due to progesterone. That's lead to constipation and reflux. Risk of gastroesophageal reflux disease, as we said, relaxation of the lower esophageal sphincter. Gallbladder status, because of risk, increase the risk of gallstone, nausea and vomiting, uncommon in first trimester. Hyperemesis gravidarum is severe and one of the indication for hospital admission in parturian, especially in the primum. Immune system, there is a modulator immunity shifting. So the body shift from cell mediated to humoral mediated immunity to tolerate the fetus. So there is a risk of certain infection like influenza and listeria. Musculoskeletal system also go joint laxity due to the relaxin and progesterone, leading to lumbar lordosis. It's a compensatory to hold the abdominal weight, and also pelvic ligament relaxation facilitate childbirth. Renal system, glomerular filtration rate increased by 40 to 50% starting early in pregnancy. Renal plasma flow also increased. Serum creatinine and urea stay normal in pregnancy, and sometimes even the values are lower than non-pregnant levels. Increase in the urinary frequency due to the increased filtration and bladder compression. Physiological case that can happen during pregnancy to the cardiovascular, or actually happens to the cardiovascular system. Blood volume increased by 30 to 50% to support the uteroplacental circulation. We will be speaking about uteroplacental circulation briefly. Cardiac output rise by 30 to 50%, peaking at the second trimester. Systemic vascular resistance drop due to progesterone-mediated vasodilatation. Heart rate increased by 10 to 20 beat per minute to accommodate the metabolic demand of the parturian and the fetus. And we have the supine hypotension due to compression of the inferior vena cava and aorta by the gravid uterus. And as I said, like 18, 20 weeks, it starts. So in general, we can say cardiovascular change, pregnancy induced profound cardiovascular adaptation to support the metabolic demand of the fetus and the placenta. Those changes begin early in the first trimester and peak in the second trimester. Blood volume increased by 30 to 50%, starting from the first trimester, peaking to 30 to 34. This lead to, though there is an increase in RBC, but there is a relative hemodilution because of increased blood volume. So we have physiological anemia of pregnancy. Volume distribution will be affected because of the blood volume, and also reduction of albumin will affect. So we have to take that with us when we want to dose our drugs, because it have impact of anesthetic drug. And I will give you an example for that. For example, in case of thiobentol, the effect of plasma expansion is increased in the peak plasma concentration. So this is due to the large volume of distribution and due to increased blood volume, and fast source. So you may require a higher dose to induce. Propofol, the dose will be the same because it's fall under effect of two things. Dilution effect, lower the total concentration, but there is a significant reduction in albumin. So there is high free active drug. So this, like against and with, will neutralize each other and the dose will not be affected. Muscle relaxant, for example, you will need increase of the dose because of the volume of distribution is increased. So you may require higher initial dose, and renal and hepatic change also may prolong the duration. For example, more examples, opioids, because of the low albumin, you will have a high friction. So there is a decrease in albumin binding. So then there is a faster CNS penetration, and this also enhanced by increased cardiac output. So, and same goes for midazolam. Uh, for that, sedative effect might be prolonged, so use with caution. For example, for lidocaine, it's like the phenytoin. There is you need to decrease the dose because there is a lot of free drugs in the blood. So there is a risk of systemic toxicity. So always adjust local anesthetic in case of you want to go for regional blocks. So we can summarize that there is increase in the plasma and increase of volume of distribution. Uh, so there is a decrease in plasma drug concentration, may blunt effect of lipophilic induction agent. Uh, the reduction of albumin will lead to increase free drugs, and that enhance the effect of toxicity risk for protein bounding drugs like local anesthetics and benzodiazepines. Cardiac output increase or enhance drug effect due to fast circulation. And renal and hepatic change alter drug clearance, especially for renal excreted agents. So there is numerous physiological adaptation in pregnancy, and this comes when we spoke about uteroplacental circulation. We have the vascular remodeling begins early in the first trimester. It's involved the transformation of maternal spiral arteries by cytotrophoblastic cells or cytotrophoblast. This is reduce resistance and allow direct blood flow intervillous space to initiate the exchange between the fetus and mother. There is a hormonal modulation due to estrogen and nitric oxide, and estrogen and progesterone enhance vasodilatation, and nitric acid and prostacyclin contribute in maintaining low resistance. If there is, for example, reduction in prostacyclin, we will face eclampsia, and we will speak about eclampsia later, not in this section. Cardiac output increased by 30 to 50% to meet the maternal demands. Okay. So a substantial portion of the blood is redirected toward the uterus. By the third trimester, it can be up to 20% of the circulatory. So uterine placental insufficiency can happen due to any disruption in normal adaptation, for example, preeclampsia, hypertension, placental infarction, and this can lead to fetal growth retardation or restriction and for example, also we have to take by consideration the maternal hypotension during regional anesthesia. Example, spinal block can reduce placental perfusion. Vasopressor like phenylephrine preferred over non-direct acting ephedrine to maintain uteroplacental blood flow without harming the fetus. Also, we have to think of uterine hypertonus. If there is excessive uterine tones, for example, during oxytocin overdose or tetanic contraction, can mechanically impede perfusion to the placenta, causing fetal distress. Venous change, increase in venous capacitance and stages, risk of varicose veins, and edema, deep vein thrombosis, DVT, and this can lead to vasostasis, endothelial injuries, hypercoagulability. All this can lead to increase of DVT. So the causes of hypercoagulability in pregnancy, let's remember that hypercoagulability state is an adaptation process to minimize hemorrhage during delivery. Prothrombotic shift involve multiple change and coagulation, in coagulation, and into or fibrinolytic system. For example, the precoagulant increase like factor 1, 2, 8, 10, and 9, even Wellbrandt factor increased, and also there is an increase in fibrinogen. Fibrinogen increased by 50% during pregnancy. Also, increase in platelets activation also increase, and also there can happen drop on platelet count due to the dilution effect, but still platelet activity is thought to be higher. So those are the causes. So we can summarize them. Increase in the precoagulant factors, for example, increases cystasis, liver stop producing almost everything except clotting factor, factor 1, factor 7, factor 8, 9, 10, 12 due to estrogen stimulation. Natural anticoagulant start to decrease. For example, protein S level decrease significantly, and there is also might be resistant to activated protein C, and slightly decrease in antithrombin 3 activity. And fibrinolysis, placenta produce plasminogen activator inhibitors, PAI 1 and 2, and those are the reducing the fibrinolytic activity and increase clot resistance. And vascular injuries, for example, enlarged uterus, compress the inferior vena cava, and pelvic vein causing sluggish venous return, and especially in the lower limb. Also, hormonal effect, increased platelet activation. So, clinical implication, there is an increase in venothromboembolism (VTA) in by 4 to 5 times in prearranged or pregnant ladies compared with non-pregnant counterparts. The risk period in the postpartum period, especially after cesarean delivery and prolonged immobility. Thromboprophylaxis is indicated for high-risk group. For example, if there is a personal or family history of VTE, thrombophilia, so you can start low molecular weight heparin. In general, we can remember that by using minimum fast 5 or V, fibrinogen and clotting factors increased, anticoagulant decrease, thrombolysis decrease, stasis, and vascular injury, especially at delivery. Murmurs and heart sound, there can be systolic flow murmur, and are quite common due to increased blood flow. And there is a split between second and third heart sound, and there is gullo breath may appear. A pathological murmur should be investigated, especially the diastolic murmur, because of pregnancy-induced cardiomyopathies. So briefly, I spoke about supine hypotensive syndrome, and I said the cause is the compression of inferior vena cava. So this reduced the venous retain. It starts in the 18th, 20 week of gestation in 10% of women. Symptoms include dizziness, nausea, pulmonary hypotension. Management, the left lateral tilt, 15 to 30-degree tilting, especially during surgery or delivery to increase the venous retain. Mhm. Nervous system, pain threshold is elevated due to endorphin and normal modulation or hormonal modulation. Let's remember that max is reduced by 30% also. Okay. There is a risk of nerve compression, example, carpal tunnel syndrome due to fluid retention, spinal cerebrospinal fluid volume and epidural space reduced. So for that, you plus the increase in the pain threshold, you may need a small dose of local anesthetic if you want to go for neuroaxial block. So, for general anesthetic consideration in pregnancy, preoperative always preoperative fasting and aspiration prophylaxis, ranitidine, metoclopramide, sodium citrate, left lateral tilt after 20 weeks of gestation. Prepare yourself for difficult airway. Okay. Always have a consent that include the fetus. Induction rapid sequence induction, a standard to reduce aspiration risk. Intermediate propofol, thiobentol as safely. Ketamine is hypotensive because it can affect the uh, maternal fetus circulation, affecting the uteroplacental circulation. Maintain volatile agent less than 1 mg because if you go more than 1 mg, there is an increase of bleeding and atony. Use minimum effective dose. Monitor heart sounds and fetal sound if the fetus is viable. So regional anesthesia in pregnancy is the golden standard, preferred technique for labor and cesarean section. Also, you can use combined, spinal epidural combined. Benefit maternal, its consciousness, minimal fetal exposure, and also there is increased sensitivity to local anesthetic. So you need to adjust the dose reduction by 25 to 30%. But there is increased risk of hypertension due to the sympathetic block. So increase the preload and use vasopressor, phenylephrine preferred over ephedrine. So effect of anesthetic drug on fetus. Most anesthetic drugs cross the placenta via passive diffusion, short procedure with a minimal drug to minimize fetal effect. There is increased risk of neurotoxicity with prolonged exposure in theory, but not confirmed yet in humans. Avoid teratogenic drugs, especially in the first trimester, like benzodiazepines, though benzodiazepines are now questionable. Also, nitrous oxide. Okay. So, in case of non-obstetric surgery during pregnancy, it's safe in all trimester and necessary, but always have a neonatologist and prepare yourself for premature labor. And the best timing in second trimester for urgent procedure. Avoid uterine manipulation, maintain sufficient uteroplacental perfusion, monitor fetal status if viable, use a lowest effective dose of anesthetic. Never use or avoid using non-steroidal because it can lead to premature closure of patent ductus arteriosus or altering the fetal circulation. Key risk and challenges, aspiration due to increase of gastric pressure, decrease of lower esophageal sphincter tone, difficult airway potential due to mucosal edema, weight gain, hypertension due to aortocaval compression and sympathetic block, fetal hypoxia, avoid the maternal hypoxia, hypertension, and acidosis, uterine atony, especially after volatile agents. Thank you for your attention.